My name is Dr. Musawa. I am a medical doctor practicing in Kenya. Today I want to talk about testicular cancer, and I welcome you all to this presentation. This is a very rare tumor that comprises about 1% of all cancers in men, and the lifetime risk of a man developing this cancer is about 0.4%. It is common in the ages of between 15 to 35 years old, and whites are more predisposed. That's they are 4 times more likely to develop in it compared to the blacks. It is a tumor with a good cure rate, given that the 5-year survival rate is over 95%. It is associated with several risk factors that predispose one towards getting it. History of undescended testes has been shown to predispose one to developing it, just not only in the undescended testes but also in the contralateral testes. And the abdominal location of the undescended testes carries a more risk compared to the inguinal location. And also, if the correction occurs after puberty, the risk is even much higher for developing testicular cancer. The other risk factors include history of contralateral testicular cancer, testicular atrophy, hypospadias, and familial history of testicular cancer. In the initial presentation of a patient with testicular cancer, usually it is a painless swelling or a nodule in the scrotum or the testes that the patient or the sexual partner will feel. Then there's this change in the feeling of the testes, whereby the affected testes become a bit more firm compared to the other. A dull sensation, or rather dull pain, or heavy sensation in the lower abdomen around the perianal region or in the scrotum can also come. Some patient just presents with sudden buildup of fluid in the scrotum. In the advanced cases, where about 10% of patients actually present with advanced cases, these are usually metastases to the various body parts, so that if there is a metastasis to the neck, patient will present with a neck mass. Metastasis to the chest, patient will have a cough with shortness of breath. The tumor also spreads to the bones, where the patient will come with bone pain and also the back pain. It is predisposed as one to getting deep venous thrombosis, so there might be unilateral or bilateral lower limb swelling. And involvement of the gastrointestinal system will lead to anorexia, nausea, vomiting, and gastrointestinal bleeding. About 5% of patients present with gynecomastia, and this is usually due to the production of the human chorionic gonadotropin by the testicular cancer, which leads to reduced production of testosterone with increased production of estrogen. So sometimes the patient has this low sexual drive. The high human chorionic gonadotropin also leads to symptoms and signs of hyperthyroidism. In the evaluation of a patient with testicular cancer, the initial investigations that are ordered include the testicular ultrasound, that is with Doppler, and also blood markers or the serum tumor markers, which include lactate dehydrogenase, human chorionic gonadotropin, and the alpha fetoprotein. Remember to evaluate the patient for metastasis, so doing a CT scan of the chest, the abdomen, and pelvis, together with a bone scan, is relevant. Treatment of testicular cancer involves radical inguinal osteectomy, and sometimes doing a contralateral if there's indication for it, doing a contralateral biopsy in the other testes is necessary. Also, doing gauging for retroperitoneal lymph node dissection is sometimes done just to ensure all the tumor burden is removed. The major complication of this treatment is infertility, since it is a tumor that is affecting the young men. So this should be discussed with the patient about sperm cryopreservation, so to overcome this problem. Surveillance screening, is there really a role? Various societies and bodies do not show any role of doing surveillance screening, which can be either through self-examination or doing those tumor markers. However, the American Cancer Society, the European Association of Urology, and the American Urologic Association recommend doing a monthly self-examination of the testes in those patients at high risk that I had earlier talked about. That is it for today, and thank you for listening.